BRCs and CRFs are two halves of one experimental medicine journey. BRCs, combining innovation with delivery, that we unlock the full potential of experimental medicine. Together, they form a powerful partnership that takes research from bench to bedside.
Collaboration has to be the way forward. We know that none of us are experts in everything, and by talking to each other, by learning from each other, that's how we can get the best research that's going to make the biggest difference.
Good morning and welcome to Birmingham. It's fantastic to see so many of you here today for the first joint meeting of the Biomedical Research Centres and CRFs and the impact of working together. What stood out for me is the phrase, the power of the people. It takes people from all disciplines with a variety of backgrounds to design and deliver the best research that is important to patients, which will lead to better outcomes. Today, that multidisciplinary team from both the CRFs and the BRCs is here, right in front of us.
And you'll know quite a lot about its history, industry, science, music, particularly in the last 50 years and so forth. And if you get a chance, there's a lot to see in this area, galleries and museums and so forth. So I hope you enjoy the city. One thing about the city that always surprises me, actually, I'm not surprised both for the quality and importance, I think. And as Lorraine said, it's all about the power of people. And so there's a fantastic programme to support that. Over the next couple of days, we'll be hearing from a lot of guest speakers from impact against those 4 I's. Those I's that are so important in everything that we do. Remember, impact. I think everybody who works in these initiatives needs a session. And of course, we've got lots of key stakeholders here today. Industry partners, incredibly important. Most of all, patients who are highlighting what we're ready to go. But before we do that, there are some housekeeping rules, if I may. There are actually quite a few more than normal, but they're really important. So just give me a couple of minutes on these. Now then, parallel sessions. A key feature of this conference, and just remember, if you haven't yet booked them, please do so on that app. Some won't be able to attend a session if you haven't booked it, so do please do that. If you don't have a smartphone or need assistance, just visit the help desk. And, as well as supporting us, I've always found talking to sponsors incredibly illuminating. I always learn things, so please do that. And the physical posters. And there's also refreshments throughout the event. You've already had some this morning. And do all review the posters in the app. And this screen down here will run those questions, and then the chair can choose what to ask. And we may not have time for lots of questions, we just have to see how it goes. But there is an interesting feature which I've not seen before, which I think is quite powerful, which is, because there are so many of you, you might get a lot of questions, but if there is a question that you particularly like, you can upload for you. So, with that, I'll finish there. Again, thank you very much for coming. It's a fantastic conference. You will enjoy it. I'll hand over to Lorraine.
Thank you, Paul. So the first towards our common goals and visions. But before that, we have Mel Calvert. Mel is Professor of Outcomes Methodology at the University of Birmingham and Birmingham BRC Theme Lead.
Thank you very much, Lorraine, and welcome to Birmingham. It's a real pleasure to see you all here today at this joint BRC-CRF conference. And also be thinking about inclusive and equitable patient-reported outcome data collection. So just to make sure we're all on the same page, what are patient-reported outcomes? Well, they allow us to capture the possibly more in the phase 3 setting, where patient-reported outcomes have been collected for many years across many clinical areas to assess the effectiveness or the efficacy in some trials of interventions from the patient perspective. And so Okay, so let's focus on why would we be bothered to collect patient-reported outcomes within early phase settings. Well, patient my experience as a result of treatment can be really understood from the patient perspective, and they can provide really valuable information to contribute to dose optimisation and scheduling. They can also aid clinicians and the clinical team more broadly in terms of reporting and better characterising adverse events and their impact on function. And they know, crucially, that inclusion of patient-reported outcomes should be considered to enhance the assessment of tolerability in dose-finding trials as well as subsequent trials. That's the value of my talk today. So I'll just give you a second, a few participants, but we already seem to be using patient-reported outcomes. So maybe my next question is not so relevant, which is, what is your main reason for the importance of PROs and how it can be translational right from your early phase setting into actually being meaningful impact for patients? So before I move on to my second part of the session, I just wanted to flag to you, so the recommendations here for you as a clinical trials community, I think is to promote the pro-collection within early phase settings. I would encourage you to adopt the FDA core concepts, or at least have a look at them, and we'll be talking about AI later, but it could be used as an input for AI and output, or to measure effectiveness. If we're only collecting PROs in a subset of our population, these results are not going to be generalisable, and we're doing a disservice to the communities that we serve. And there can be a number of barriers. Stylus is something to help, because actually trying to use fingers, if they've got rheumatic fingers with quite sore or painful to be trying to swipe on apps and things. There might be issues around cognition, general poor health. Also literacy in digital health. We also know that there are racial and ethnic disparities, there are a lack of translated and culturally validated measures. That I think is improving, particularly for some of the common measures that are used. They have been translated and culturally validated, but not for all. We know that underreporting of ethnicity data is within the clinic anymore, and they ask them to complete at home on a portal. And we can see here that they did an analysis by race, and they found that Hispanic or Latino or Black or African American participants were completing much less frequently than clinics. But here, the majority of participants wanted to complete at home, shown in blue, or wherever they want, in yellow. And actually, in healthcare settings such as hospital, clinical, pharmacies, shown in green here. So we might need to start thinking about where we collect these data and how to do so. The idea is to make it more accessible for people to complete patient-reported outcomes. Accessible. So I think there's a lot we can be doing here as a community here today to really help enhance the PRO data collection. And here, in a paper led by with Sam Cruz-Rivera, we highlighted actions to promote representation and participation of underserved groups in PROs, and we did a roadmap really thinking about that. And if your trial's going to inform regulatory approval, you also need regulatory engagement. So to summarise, from the patient perspective, so I'm absolutely delighted to hear that about 75% of those that voted said that they were already doing this. I'm preaching to the converted, but if you're not, or if you're thinking about this further, I would really encourage you to do so, I've mentioned today. And our brilliant team, which are listed here, and our patient partners, who have been amazing in supporting all of our activities throughout this project. So thank you very much, and please put any questions you may have for me on the Slido, and I believe we're picking them up at the end of the plenary session. So thank you very much for your attention today, and enjoy the rest of the conference.
Thanks, Mel, for that really insightful talk. As Mel said, DHSC and NIHR priorities for the research systems and the context in which we work. Thanks, Natalie.
Thanks very much, Lorraine, and thank you for having me here. It's great to see so many people. I think this is probably the biggest crowd I've ever spoken to, so be thinking quite broadly along the government's health and growth missions. But today I'm going to mostly talk to you about the recent publication of the 10-year plan. So the first couple of slides are reminders of the policy landscape in which we work. The first is the health mission, which is an NHS there when people need it, fewer lives lost to the big tomorrow. So I shan't be stealing her lines first thing this morning. So here we come on to the 10-year plan, and this really reframes how healthcare is delivered and funded. Obviously we think this transformation should be... Say that the 10-year plan team carried out a huge programme of consultation, and I do hope that many of you here in the room fed into that. And obviously so this plan does reflect public priorities, and that's shorter waiting times, more local services, health equity, and a system that works for patients and staff alike. So, smarter technology-enabled services and a shift from reactive to proactive patient-centred care. And the plan states that this will be achieved through the 3 system-wide structural shifts, and we've been talking about these with you for many months now. We balance the provision of care in hospital closer to the community by investing in neighbourhood health teams, and these are built around general practice, pharmacy, mental health and community nursing. Home-based care to reduce admissions and help people live independently for longer, and better integration with social care to reduce discharge delays and support and clinical support, and launch an innovator passport to fast-track digital tools and devices without repeated local approvals. And the final one is of the 3 shifts is sickness to prevention, and prevention is NHS plan. So alongside the 3 shifts, core priorities and policy areas, you'll be relieved to hear that I'm not going to mention everything in the 160-page plan. I don't think the organisers would thank me for having you glaze over and start praying for the first coffee break. So I'm just going to run through a few of them. So tackling inequalities, the plan's 7 days a week. We've heard from patients and the population that they want to see improved access and waiting times, and the plan introduces national waiting time guarantees, but new surgical hubs and diagnostic centres to reduce backlogs in hospitals, and an integrated single front door for urgent care. We appreciate that that takes time, and there'll be new roles in mental health, public health and social care. Coming back to mental health, we want to see that integrated, and we want to see that parity of esteem as a recommitment to the parity of esteem between physical and mental health. And we want to see expanded talking therapies and digital self-help tools, early support in schools, youth hubs and in perinatal services, and specialist support for neurodiversity and trauma. Again, coming back to obesity, smoking, alcohol use and inactivity across a huge workforce. And the last thing I'll mention is innovation and technology, and actions include the tech passport to fast-track those trusted innovations, as I mentioned earlier, expansion. So what does the plan mean for research specifically? You thought I'd never get to that bit, but here we are. As I said, research and evidence is applicable to all and every aspect of the 10-year plan. But here I'm just going to highlight some of the areas that are more pertinent to the earlier stage research infrastructure, the BRCs, and the people with one long-term condition go on to get 2 to 3 to 4 to 5 conditions with associated be parts of research. And please. And it says we will also be a world leader in clinical trials and patient involvement. involvement in research. I think we as NIHR can tick that last box in the plan already. We have excellent PPIE and it's always been embedded across our research. But there is more to do on set-up times and recruiting to time and time. But the point being that we know there's huge frustration out there and it wastes a lot of time, resource and energy with you just trying to get hold of the data and have that curated in a way that works for you. So we need to support you here and for you to tell us what you need. And a huge thanks to all of you that have been working with us through the data informatics group led through the BRCs but involving other parts of the infrastructure. The last one I'm going to mention here, you can see that I've skipped. The HSC, along with other stakeholders and the devolved governments, are developing the UK Research Workforce Strategy, and that's due for publication in the autumn. And this strategy outlines a vision for embedding research and innovation into routine practice within the NHS, within primary care, social care and public health over the next 10 years. And the strategy will cultivate a robust during the transition year, delivery has continued. There's been a recruitment of over 1 million participants into over 5,000 studies, which is pretty impressive. So in 2026-27, the RDN is going to adopt a new funding model. So a agreed model across the whole country, where funding is allocated in a more transparent, fair and predictable. So thank you for having me.
So, with updates from Sol Frost, who is Chair of the CRF Network and Clinical Leader Director for the Southampton CRF, Paul Brown, Director of the UK CRF Network, along with Mike Grocott, who's Professor of Anaesthesia and Critical Care.
Involvement in the CRF world and UK CRF network, and as a result of that, my normal slot to update you on football and the fortunes of Leeds United, unfortunately, absolutely no time for that this year, so moving swiftly on. With us for a few years now, pulling together these conferences nationally, and then from our ops team, the wonderful Sophie Black and Lucy Sanger, who work tirelessly each year to make this happen. It's fantastic to share the stage with Kay and Mike and do this as a joint thing for the first time. And I think it really does emphasise that. The big thing is we've expanded now to a membership of 60 CRFs. And I think there's a few things I want to point out here. Firstly, Sol's a paediatrician, you may mention this, but the re-establishment and growth again of our paediatric CRF to our way of working. It couldn't happen without our governance and our structure. And sincere thanks from me to our senior management and leadership teams. I'll talk a bit about the work packages in a moment and the various people behind those. But this is the first year we've had full UK representation on our senior management team, and we've welcomed Roisin Martin from Northern Ireland into our number. And just from a personal perspective, my four other members of the senior leadership team for giving me their help, encouragement and guidance to be able to oversee this burgeoning network. Okay, so I made them stand up and embarrass them last year. There simply isn't time for